All right, welcome to everybody who's in the process of joining us. I know people are going to be trickling in, but in the meantime, my name is Bettina. I'm one of the scholarly communications managers here at the Annals of Family Medicine, and I help to kick off all of the mini grand round sessions that we have today. We're joined by Dr. Ellen Meltzer from the Mayo Clinic out in Arizona. She's an internist by training, but is clearly very busy because she's got 3 different titles. And she's senior leadership and director, both at the Mayo Clinic's Office of Experience, a director for the Performance Improvement Unit within the Office of Clinical Ethics, and a co-director for the Clinical Ethics Consultation Service. And a practicing internist as well. So we're here to talk about her paper. And with that, I will go ahead, as you have questions, add them to the Q&A box. We'll filter those through and make sure that she sees them. She'll go through a presentation about her paper on the use of electronic health records during clinical encounters. And at the end, we'll take time to answer some questions. In the meantime, we know we had some students from Ohio State that were going to be joining us. It's actually my alma mater. So if you are here, please do let us know in the chat, and we encourage you to ask questions. With that, Dr. Meltzer, if you want to take it away.
Thank you so much for having me. After that warm introduction, I don't think I need to provide any additional information, but I'll be talking about use of the electronic health record during clinical encounters, an experience survey that we did at Mayo Clinic in Arizona. Just in brief, I am medical director of the Mayo Clinic Arizona Office of Experience and also am co-director of our Clinical Ethics Consultation Service. And my interest in experience really grew out of the work that I do in clinical ethics. And I'll talk a little bit more about that in a few minutes. So why the electronic health record? We all know that the electronic health record is intended to promote safe and efficient, high quality medical care, but using the EHRs, I'll refer to it during this talk, during a clinical encounter can really be controversial. If you use the computer and try to document and enter orders during the visit, this could result in a negative patient experience, with a patient left feeling unheard or perceiving the physician as being distracted or less empathic. And this is significant as a poor patient experience is correlated with negative clinical outcomes in the literature. But for us physicians, the electronic health record has been associated with work-related dissatisfaction and burnout. Some physicians find using the EHR during a clinic visit intrusive, but later they lament the hours out of the office that they spend documenting and entering orders. Other physicians prefer to engage with the EHR during the visit with the patient present, but again worry that they might appear distracted. And really, there's no clear answer from an experience perspective on how best to proceed. So while experts have developed a set of recommendations and best practices for incorporating the EHR into a clinic visit, and I show one helpful mnemonic here, human level, 10 tips to enhance patient-centered EHR use, the data on whether these skills clearly impact patient and physician experience remains unclear. And I am very appreciative to this group. They collaborated with me on my study by allowing me to use some standardized surveys that they had already developed for my own project. So in addition, we've never looked at Mayo Clinic at patient and staff experience with the EHR, and we were eager to do so. Thus, my goal was to conduct a baseline survey of patient and clinician experience with and attitudes towards EHR use during the clinical encounter. And I was really interested in understanding what the current state was, and for the purposes of performance improvement, using this data to guide future experience efforts. So in brief, we did a survey study. We had both a clinician survey and a patient survey. Both were adapted from existing published tools. Our clinicians self-reported how often they employed those EHR behaviors thought to be associated with a better patient experience. And patients, after a visit, subsequently reported whether the clinician they saw that day implemented those EHR specific skills. Both groups also rated whether they felt the computer impacted communication during clinic visits, and our clinicians additionally reported on burnout. While a full review of the demographics is beyond the scope of this talk, it can certainly be found in the Annals of Family Medicine. I briefly want to present some demographics here. This is our clinician demographics. You can see we had a mix of different health care providers. Majority graduated medical school between 2000 and 2009, and about 50% thought that they had been involved in some education or training on EHR specific skills. Here's our patient-related data. Overall, we had a 45% response rate, and based on those that actually completed the surveys and turned them in, it was a 58% response rate. You can see that at Mayo Clinic, Arizona, we have a fairly educated white patient population, and I'll come back to this later when I discuss limitations. So here we see our clinicians self-report about whether they largely employed the 8 behaviors thought to be associated with a better patient EHR experience. And you can see that they do. They fairly often, very often or always employ the majority of the behaviors. But you can see in orange that there are 3 behaviors that they report they never or rarely employ. And I want to highlight these for further discussion at the end of my talk. Those are asking the patient permission to use the computer during the visit, explaining how the computer helps us to take care of patients, and letting the patient know that they believe the computer to be a positive part of the visit. Similarly, when we asked patients, they largely reported that the clinician they saw that day, if they did use the EHR during the visit, had largely employed these behaviors. Again, aside from the 3 behaviors noted in the prior slide, we see more orange there in terms of strongly disagreeing that the clinician had employed those. This slide presents data on clinician and patient experience. Each of the paired bars shows the clinician and patient perspective on the same statement. And you can see how their experiences seem almost completely contradictory. The HCP, the healthcare practitioner, versus the P, the patient. Clinicians feel that because of the computer, they maintain less eye contact with patients, they listen less carefully, they focus less on patients, and the visits feel less personal. Patients completely disagree. They report sufficient eye contact, being listened to carefully, and disagree that the clinician focused less on them and that the visit felt less personal. Interesting data, particularly as we seek to better understand how the EHR impacts experience of both of these groups. We did administer the mini-Z burnout survey, and I encourage those who are doing research in primary care or experience work to consider incorporating some type of similar metric, because it really gives us insight into how what we're studying impacts the day-to-day experience of our colleagues. Most notably, 62% of respondents felt that the amount of time they spend in the EHR at home is moderately or excessively high, and 86% report satisfactory, good, or optimal EHR proficiency. It was initially my concern that a lack of EHR proficiency could be contributing to some of the time spent out of office hours documenting, and that did not turn out to be a positive association during our analysis. So in terms of other associations, there was only one positive association in our data, and this is represented here in this bar graph. Of the clinicians who enjoyed their work and had no symptoms of burnout, 75% reported working less than 2 out of office hours per week documenting in the EHR. But we see as burnout increased, so did the number of hours spent out of the office documenting in the EHR. So clearly out of office hours working in the EHR is a detractor for our colleagues and contributes to burnout. I'll mention one association that was not positive, but is worth mentioning in light of this. I was hoping that we would see that colleagues who do more documentation in front of the patient during the visit would spend less time out of office hours documenting in the chart. And that did not bear out in our research. And what it points to for me is that there are things other than just documenting and entering orders that take up our time. And when I spoke with my colleagues about this afterwards, we had extensive discussions about in-basket management and how this is largely responsible for that time. Returning calls, responding to messages out of their regular hours. So a couple of points, and my takeaway messages from this study. Patients feel that using the EHR during a clinical encounter is a positive thing, but my colleagues don't think patients feel this way. And that's really important. One, it's consistent with prior studies, but it suggests the need for further clinician education on benefits of the EHR, how patients really do appreciate it, and how it helps them to better understand their results and their plan of care. I think that this mismatch between attitudes and experience with EHR use, the slide that I showed you with the bars between clinicians and patients, may serve to decrease clinicians' use of the EHR in the clinical encounter. For patients, this could be detrimental since they think it's positive and improves their understanding. I'm not sure that it really affects my colleagues, our clinicians. It doesn't seem to decrease hours spent out of the office, even if they're documenting in the EHR. But certainly it requires additional study. Patients don't report a negative experience as a result of EHR use during the encounter, while my colleagues did. And I think that this really highlights the importance for interventions to improve clinician experience at work. And something we're focused on at Mayo Clinic, how do we reduce the burden? Out of office hours work is significant and associated with burnout, and we need strategies to address this. I want to briefly mention an e-letter that this group from Ohio took the time to write after reading and discussing the paper. And I post the letter here with their permission as it highlights some of the limitations and challenges of this work. So they mention that the study was conducted at a single academic institution with a relatively homogeneous primary care clinician and patient population with a higher education level. And they're absolutely right. This is always going to be one of the limitations of the work that I do at my particular clinical site. And these studies should be conducted in non-academic and in rural settings and among patients with different levels of educational attainment. This is critical because we want to try to help improve the experience of both patients and our clinical colleagues. And it's really important to understand if we're proposing any types of clinical practice changes, how this might affect both of those groups. And understanding how patients perceive and respond to use of the EHR is critical. They also mentioned that I have a high response rate and the majority of responses coming from physicians. I think that's primarily based upon our makeup of our clinical staff, and there was no significant difference in responses depending on occupation of the respondent. There was also no significant difference based on year of graduation for the respondent from my clinical colleagues. So none of these demographic factors bore out to be significant when we looked at regression analyses. I do want to note that all clinicians at Mayo Clinic attend mandatory communication skills training as a part of the onboarding experience. And they're really not specific to EHR communication skills, although almost half of my colleagues in this study noted that they had attended some type of EHR specific training. But I think that overall, these communication skills training courses serve to enhance our communication in general and contribute to this positive experience that our patients have at Mayo Clinic. Finally, I want to come back to this slide. So for those of you who are already incorporating EHR use into your clinic visits, and for those of you who are thinking about doing more documentation during the visit, reflect on these 8 behaviors we use, as well as those presented in the literature, such as the mnemonic human level. Are you incorporating these practices? Most are really easily done, and you're probably already doing them. But back to the 3 that I highlighted earlier. As a clinical ethicist, I frequently teach about and am a firm believer in promoting autonomy and self-efficacy. These 3 communication skills were of particular interest to me. Asking the patient for permission to use the computer during the visit was nothing that I found in the literature. It's one that I was interested in asking about, and I asked my clinical colleagues to reflect on this and whether they thought it was important. there were sort of mixed reviews. Why would we ask the patient permission if it's something that we use versus interesting idea, maybe it would serve to engage the patient more in using the EHR during the visit. I think that explaining the benefits of the EHR, and those two at the bottom are promoted in the literature, and explaining how it helps us to care for patients, as well as engaging the patient in the decision to use it during the visit, is key to promoting patient-centered use of the EHR. We're all in agreement, we're engaging the patient, and we're showing them how it can help us to better care for them. But as you saw from the previous data, not all of my colleagues think the EHR is such a good thing. Finally, I want to thank the analysts for supporting this work and for providing me an opportunity to present today. I want to thank and acknowledge all of my collaborators at Mayo Clinic, as well as the Robert D. and Patricia E. Kearns Center for the Science of Healthcare Delivery for Practice Innovation Award to support this project. And finally, all of the respondents, patients, and clinicians who made this study possible. Thank you, and I would be delighted to take any questions.
Thank you, Dr. Meltzer. We've got Abigail Burke, who's joining us from the Ohio State group, who sent in the e-letter, and she's joined by a colleague. So I'm going to do a few clicks here so that they can, if they would like to, ask questions verbally or via camera. But I think you did a great job at answering some of those questions, and it's I don't know, Abigail, maybe you can let me know if you are willing to maybe talk about some of your thoughts to the response.
Yeah, hi, thank you so much, Dr. Meltzer. My colleague Bridget is also on, and I apologize if my internet is going in and out. We all love Zoom here, but yeah, so we are in a class at Ohio State University where we talk about primary care and kind of the difficulties that primary care in the US entails and comparing it to other countries and their primary care systems. So one of the parts of the class was to read some of the journal articles that was in the Annals of Family Medicine and respond to it and look into it more. So we really found this article in particular to be interesting and applicable to us, as hopeful future clinicians. And I think it's very applicable to us, and there's a lot to learn from it, and a lot of future directions. So this has been really interesting, and I really appreciate the time that you all have taken to talk to us about it. So thank you.
Yeah, I certainly appreciate that. It's doing research in primary care settings is obviously very important. And for those of us who practice or have practiced in those types of settings, I've always considered it a bit of my lab. And so my first interest in experience work came from looking at practice I was in New York City and trying to think about how do we improve the experience of patients and clinicians in all different types of practices. So, and obviously there's always going to be ethical issues and problems to solve in primary care.
Of course, there's kind of a, from what we've had in our one singular class of, a couple months so far, we've just kind of seen a laundry list of different things that are going on in the primary care world, especially in the US. I just wanted to, if we have the time real quick, ask about, in particular, I found that the difference between the clinician responses and the patient responses to, and, I know you touched on this in your presentation, but it was so opposite and something I really didn't expect. And I'm curious, why you think that might be. Is it that, clinicians just kind of have this, well, everything needs to be absolutely perfect. And, we're all kind of perfectionists and want the best for patients. Or, is there another reason? because clearly the experiences of the clinician and the patients are very different with EHR use. So I was curious, from your perspective, why that difference is so big.
Yeah, it's a great question. I think there's a few different reasons. One is that naturally placing a lot of pressure on ourselves to deliver this, as you've described it, this perfect or best patient experience. And, do we feel like we're distracted when we're looking at the computer and not fully engaged with the patient? There could be I think that could be a component of it. I think it also reflects an overall general frustration with the electronic health record and with the volume of information that's now available to us. It's very helpful in some ways that we have access to years of records and outside charts, but also the volume of reviewing that and being on top of everything, I think, contributes to an overall sense of pressure that we're feeling there. Irrespective of why people are feeling this way, I guess because we know that people are feeling this way, we need to better understand how to address it, where that's coming from, and what measures might serve to alleviate some of that tension, whether it's having a scribe so that they can purely sit and focus on the patient, because that's a very different experience. If I'm seeing a patient and taking notes by hand versus typing, I'm going to have a different experience during that interaction as well. So I think for each individual person and each practice, understanding what their workflow is, where the pressure or pain points are, and then developing a targeted intervention to try to alleviate that. So for some practices, it might be having a scribes. Other practices are experimenting with global dictation, where what they're saying is sort of automatically entered into the chart. And some of my colleagues just prefer to sit and listen. They find it more relaxing and more enjoyable to really engage with the patient and kind of ignore the pressure of the computer for the time being. My only concern is then what's happening after that visit and what's happening with patient messages and the after hours work. And practices are adopting workflows for that as well, with physician and allied health staff partnerships and working in teams to try to respond to patients quickly during the day. Unfortunately, I don't think there's one quick fix for it, but it's important to understand any intervention that we're doing, how is that going to impact our colleagues who are living and practicing in that environment every single day.
Yeah, that makes a lot of sense. And I appreciate the emphasis on specific interventions for different, institutions and different practices. I know my peer Bridget has a question, I think. I'm not sure if any, clicking needs to be done to, all right, thank you. And thank you so much again.
Hi, I'm Bridget Rogers, also from OSU with Abigail. Thank you again for having us here today. It's been really amazing listening to you discuss the paper further. And, as aspiring physicians, it's really great to have this opportunity. I was just curious, in the presentation, in the paper, you noted that there was a correlation between lower burnout rates and fewer hours spent outside of the clinical hours reporting in the system. Did you notice in those cases where they noted like lower burnout rates and lower number of hours spent doing this reporting, did those clinicians tend to have more positive views of the system? So did those specific respondents have a more positive view of it?
That's a great question. We did not look at that analysis, but I think it's a great point. How does burnout impact one's view of, one's view of work or of the EHR in general? There's another survey which I was intending on using in a study I'm doing currently, but ended up not. It's the Professional Quality of Life Survey. and looking at how burnout or different interventions at work might impact somebody's professional quality of life. So there are other tools I think that would be helpful here as well. That's a good point. We did not look at those associations.
Okay, thank you. Yeah, I definitely think it'd be, an interesting avenue to see if there is that correlation potentially.
Yeah, absolutely. And one of my colleagues at Mayo said to me that his thought was that there are people who are going to have, like anything else, there's sort of a bell curve, and there's people who are going to have really great communication skills with their patients. And obviously communication skills can be taught, but his thought was that these people were going to demonstrate excellent skills irrespective of whether or not the computer was there, because they would modify what they were doing in light of the computer. And I appreciate that. I do think these are things that can be taught though. And in particular, the simple things like turning the computer towards the patient, not looking directly at the computer if the patient's discussing a sensitive topic with us, turning away, facing the patient, responding empathically. Those things can be taught, but this idea of our thoughts and feelings towards it, towards the EHR, I think that bears further understanding. And does it matter if we have a negative feeling towards it? I'm not sure, but I think as you point out, if that negative feeling contributes towards a poor experience at work or towards more burnout, so is it our thoughts and feelings? Is it the time spent? It's so hard to know, but it's, again, it's I guess sad or unfortunate to me to think that we're in a situation where people are really struggling and we're not responding to it.
I found that a really powerful answer, I think. I know we're just about to hit our time threshold. I think, are there any other questions or comments from the Ohio State group? Sounds like a resounding no. Well, we want to thank everybody who did join us for taking the time today, particularly Dr. Meltzer. We do host these basically for every journal or for every new issue that we publish. So that's about once every 3 months with some exceptions. So please do keep a lookout for those. The recording will be posted up on our YouTube channel. So if you do have friends or colleagues who couldn't join us today live, they won't miss out on the content. So keep an eye out for that. And otherwise, thank you all for joining us. Have a great day.
Thank you so much.
Thanks, Dr. Meltzer.